and we call it workstation. It basically takes away all our stress. It does everything for us. Monitoring, giving anesthesia, maintaining anesthesia. It has got built-in ventilator also, which takes care of the breathing of the patient. So I really don't have to do anything. Once the patient is intubated or on ventilator, I literally have my hands free. If the patient is fine, I can have sip of coffee also. Of course, in the room, we don't leave the patient and go out. So everything can happen here. Now, can you name a few drugs that we use in general anesthesia? Very good. So we have propofol,
Ketamine,
what else? Ketamine, very good. Thiopentone sodium, very good. What else? Have you heard of etomidate? That's a newer agent, very famous. We use in, it's very cardiac stable. So in patients where BP is low and we don't want any fluctuations with heart rate or blood pressure, we use etomidate. So, and how do you give these drugs? Through rice tube, tablets, or inhalation? All these drugs are IV. Very good. So we call them IV anesthetic agents. See, I have a different, funny way of teaching. So don't feel offended if I ask you stupid questions. But see, jokes are something that you will remember. If I just give you theory, you won't remember anything. So IV agents. We call them IV induction agents or IV anesthesia agents. What do you mean by induction? Inducing the patient. So induction is a word that we use basically when we are giving anesthesia or introducing anesthesia to a patient. I'm talking about general anesthesia. Okay, so we use IV drugs. So this is about anesthesia agents. Any other drugs that we use along with anesthetic agent during induction? Yes? No. Not for maintenance, for induction along with these agents. Inhalation, I'm talking about induction. Remifentanil. What kind of drug is this? Is this an anesthetic agent? No. Yeah? It's an opioid. And opioid are which category of drugs?
analgesic,
Very good. Analgesics. Why are we giving analgesics? What is the use of
pain
analgesics?
relief,
Well, then why did we give propofol? Don't you think that will take care of pain? Yeah? Louder.
sedation,
It's not exam. I'm not going to give you any marks. So propofol is for sedation, for induction of anesthesia. It has some analgesic properties, but very little. So we need to add an analgesic. Why are you adding painkiller? We're giving anesthesia. It should be smooth, na? Why are you giving painkiller? Painkiller is not given for induction. It's basically what's going to happen after induction. You'll have some stupid person standing next to the patient, cutting the patient down. Surgeon. So it is given to make sure that patient does not move or shout when. Please edit this part. I'll be kicked out of the hospital. So during surgery, there will be pain. To avoid pain, painkiller is given at the time of induction only. So opioids are one type of induction agent that we use. Analgesic that we use. Remifentanil is not available in India. It's there in Western countries. It's a very nice drug. We won't go in detail. The class is not about pharmacology. You can read all that in books. So remifentanil, fentanyl, L-fentanyl, Fortwin, butorphanol, these are the common agents that I have experience of using. Okay. Depending upon the patient, we choose the drugs and then use it. So anesthetic agent is done, analgesic is done. What else do we give in general anesthesia other than these two? Very good. Muscle relaxant. Why muscle relaxant?
Like we intubate the patient, right?
Very good.
So for that you have to relax the muscles.
So in general anesthesia, she's saying we intubate the patient. Do we?
Yes.
Yes, because we use workstation, ventilator to take full charge of the respiration of the patient. How do you take full charge? Can I, while you're awake and standing, can I put a tube inside your throat and push air into your lungs and take out as and when I need it? No, that's not possible, right? He's going to fight. So we need patients to be completely relaxed so that we can take complete charge of breathing. we want to make sure that all the reflexes are obtained. Okay, for that we use muscle relaxant. So it makes your patient calm for endotracheal intubation, and patient gives you full control over the breathing. So ventilator will take care of the oxygenation, tidal volume. You know what tidal volume is, right? The respiratory rate, and will decide how much anesthetic gases should go inside. Now comes the role of anesthesia gases. Gases we use for maintenance of anesthesia. So your induction is done. How did we do it? Analgesic, anesthetic agent injected. Patient is sedated, completely paralyzed. We check for eyelash reflex to see whether patient is deep or not. After that, we check whether we can ventilate the patient. Do you remember that part? Where you place the mask, you use the bag and press it and see. When you're pressing the bag, air should go inside the lungs and you should be able to see the chest rise. If there is chest rise, that means I'm able to ventilate the patient. If I give muscle relaxant now, the patient will be completely paralyzed. But I'm confident that I will be able to intubate. Okay. So once muscle relaxant is given, we have given due time for the onset of action. Now your patient is ready for laryngoscopy. Laryngoscopy done, tube inserted, tube checked. How do you confirm the endotracheal placement of ET tube?
Auscultation or X-ray.
X-rays, yeah. So all the patients who are in operation theaters, we do X-rays, right?
No.
You don't do X-rays, right? Do you do X-rays? No, X-rays. It's not possible, no. It's not feasible, right? So auscultation is one, but I expected more from you. Where are you living? 18th century? Chest rise, come on.
Capnography.
Capnograph. It's a very good tool. Gold standard to confirm endotracheal position of ET tube. If you have capnograph, you can immediately tell whether you are in the esophagus or in the trachea. If you are in the trachea, you get the graph. If you are in the esophagus, how much you ventilate, it won't come. Once capnograph comes, that means you are in the tracheobronchial tree. We are still not sure whether your novice anesthetist has inserted the tube in the right bronchus or it's in the trachea. Not in the left, in the trachea. It never goes, very rarely goes into the left, it always enters into the right. If you push it further in. So how do you confirm whether both these sides are adequately ventilated?
Bilateral distance.
Yeah, so we auscultate. Bilateral 5-point auscultation. You remember that? Infraclavicular, infraaxillary and epigastric. Will you get anything here if there is endotracheal intubation? No. This is to confirm that there is no esophageal or esophageal intubation. So patient is intubated, right? Patient is still sedated because you gave propofol. What is the duration of action of propofol? Guess the number. I'm asking question, he's making notes. Yeah? Duration? 10 hours, 20 hours?
5 to 6 hours. 5 to
5
6
hours? She's saying 15 minutes. Do you believe her? So it's roughly around 10 to 15 minutes. You're right, 10 to 15 minutes, depending upon how much you're giving. Depending upon the metabolism of the patient. Assuming the patient is healthy, then roughly around 10 minutes is also slightly on the high side, 5 to 10 minutes. Now just imagine you gave the drug which made the patient unconscious. Now we want a patient to be unconscious for the surgery, right? This is what we discuss in GA. And the patient is conscious and doctor is operating, he's going to make eye contact. If I'm a doctor, I cannot operate, man. If somebody is looking at you and you want eyes to be shut, patient completely unconscious, right? So if the duration is less, then we'll have to give boluses, right? But do we do that? If you're giving boluses at regular, every 5 minutes, just imagine you are giving 10 cc, every 5 minutes 10 cc. So you need one person for that job only. Or you use, have you heard of infusion pumps? So these are the infusion pumps in which you attach syringes, and once they are on, they inject the drug intravenously or wherever it is connected at a regular rate. Okay, so do we use that? There was a time when we were using boluses. Nowadays we have good agents, good inhalation agents, which can be used for maintenance of anesthesia. So we use this machine. Once the patient is intubated, how do you give anesthesia gases? Through endotracheal tube. It gets absorbed from the capillaries into the lungs, from the lungs into the capillaries, and then to the brain, and you get the effect. So how do you give the drugs? So your the circuit is disconnected. You must have seen machine, right? Anesthesia machine. This is the first time. Have you seen pictures?
Yes.
You must have seen videos on YouTube.
Yes,
So you can't say that you have never seen. Come on. So this is the patient, and so you get two tubes which gets combined, and once the patient is intubated, the tubes are connected to the endotracheal tube. Okay. Once this is done, what I am going to do to keep the patient alive, which gas is required?
Oxygen.
Very good. We need oxygen to keep the patient alive. Thank you, sir. So we need oxygen to keep the patient alive. How much oxygen do we need to keep the patient alive? Guys, look here. How much oxygen is required to keep the patient alive? Quickly. Very good. Why 21%?
That's the normal
Is that so? You're taking 21%?
Yeah.
How do we know? What if you're taking more than rest of us?
That's combustion of oxygen in air.
Very good. So 21% of air is there in the atmosphere. If the lungs are absolutely fine, patient would maintain 100% saturation with 21% oxygen. But do we give 21% oxygen with anesthesia machine? We give slightly higher. We never give 21% of oxygen and rest there. We give sometimes a ratio of 50-50 or 60-40. So if I'm saying 50-50, so 50 is oxygen. What is the rest of the composition?
Nitrogen.
Right? You know, 60% of isochloride.
नाइट्रोजन भी होता है.
Fresh gas, the other like volatile gases.
Got confused, no?
Yeah.
So we never give 100% oxygen. One thing, it's not required. Second thing, it's harmful. It can cause atelectasis of the lungs. Okay. Secondly, if it's a pediatric case, because of free radical production, it can cause further changes in the lung parameter. We don't know that. So we mix it with compressed air. By air, I mean atmospheric air, which is compressed in these cylinders and then coming through the tubings connected to the back of the machine. So your oxygen is getting diluted by compressed air. So the air which is coming through here has got 50% oxygen and 50% of those compressed air. Now just imagine, in that compressed air also you have 21% oxygen. Yeah? So 50 parts of this, 50 parts of this is going on. Now we're gonna, depending upon the anesthetic agent, we will remove few parts. Like if I'm using ice, so my first question was, to keep the patient alive we need oxygen, right? But we cannot give 100% oxygen, so we dilute that with compressed air. Back in the days, we were using nitrous oxide also for dilution. So 40% oxygen, 60% nitrous oxide. This used to be the common combination. But nitrous oxide, what is the half-life of nitrous oxide? It's very high, more than 100 years. That means the first anesthetist who used nitrous oxide, that agent is still there in the atmosphere. It's present, it's there, because the half-life is more than 100. History of anesthesia is, I think, 1910, 1950s, I forgot. Story is very interesting, read about it. So it's still there in the atmosphere. It causes, nitrous oxide basically is dangerous for the environment. It is one of the factors of ozone layer depletion. And it has harmful long-term effects on human bodies also. So anesthetists or anesthesia technicians or surgeons who are operating in the room and we're taking the gases, some amount of gases goes into our body also, can lead to deleterious effects. I've not seen anybody who has got these effects, but it's mentioned in the books. Okay, so don't get scared. You never know, in the night you're calling your parents, how can you do this to me? Okay, so to keep the patient alive, oxygen is given. To keep or to maintain the anesthesia, we use anesthetic agent in the form of gases. but it never comes in the form of gases. It comes in the form of liquid.
Liquid.
See the problem in our lives. Things are not straightforward. So it comes in the form of liquid. So we use various devices like this one here to convert it from liquid form to
Gaseous form.
What is the name of this device? If you name this device, then sir will do something. With the chocolates? Yeah. Vaporizer. Very good. Who named it?
We too.
Sorry, you won't get it. I'm just kidding. So, you will, this is vaporizer. You won't get anything, I'm so sorry. Just kidding. I was so sure that you won't remember. Okay, so vaporizer, and what type of inhalation agent is that in this vaporizer?
Sevoflurane.
You think I'm stupid. It's written here. Sevoflurane. And vaporizers are color coded. This one is yellow in color. Sevoflurane is always yellow in color. Then you have violet, which is isoflurane. So do you remember the MAC value of sevoflurane? This question is above your head. Read about it. For inhalation agents, MAC value is important. It's minimum alveolar concentration of the drug to prevent surgical response in 50% of the population. It took me 5 years to remember this definition. So MAC value, you can just mug it up. That is the concentration that you need to maintain the level of anesthesia in general anesthesia. For SIBO, it is around 2%. For isoflurane, 1.1, 1.2%. For desflurane, I think 6 or 7%. 6%. So depending upon the agent, it's been long. I've used desflurane long ago. My favorite, my personal favorite is sevoflurane. Why? Sevoflurane is my favorite agent. Why?
Because it has lowest MAC.
Very good. So, no, what did you say? I'm so sorry.
Less MAC, high potency.
Desflurane. That is high, but it's highly potent.
Desflurane is 6, right?
MAC is 6.
Mark is 6.
But why
so it will be
sevoflurane is so good?
It's
I like pediatric anesthesia. Okay, my favorite type of anesthesia is pediatric anesthesia.
pleasant smell.
So the smell is fruity smell. Okay, now just imagine I have a patient. So suppose we have him, and he's like, sir, I want to get my nail removal, but I don't want local, I want GA. I go, all right, we'll give you GA, but I don't want any IV pricks on my body. Okay, whatever IV you want to take, you take it after anesthesia. I won't let you prick my arms for it. Now, how will you induce the patient? If he doesn't let you take an IV excess, you cannot give the drugs. So there's something known as inhalational induction. You can use these inductions to induce stupid child like him. So sorry, just kidding. So for pediatric patients, this is a very good induction. Isoflurane has pungence. Desflurane also is not. Before this, halothane was the agent of choice. It was widely used for induction. But then it had a lot of complications, so it's not being used. So you're using this for maintenance of anesthesia right now, not for induction. You read, it's again out of your syllabus. First you learn the basic, then you read about it. How can we use this for induction? So this we keep near MAC along with mixture of oxygen and air. This to maintain the anesthesia. Now this will keep your patient anesthetized, sedated. But the gases that we're using doesn't have muscle relaxant. Right? We need to make sure that patient is not breathing, because if the patient starts to breathe on its own, it's going to fight with the ventilator. Because ventilator is set at a certain rate. Patient is intubated, venti is set at a rate of 16 beats per minute. The patient started to breathe, and now your muscle relaxant's concentration is also going down. The patient's body wants to breathe at 22 beats per minute. Your ventilator is giving just 17 beats. When patient is it's expiratory phase for the patient. At the same time, ventilator is trying to push the air. There will be asynchronization, and patient will start to move. Second important thing is there is no muscle relaxant. It's lightest stimulus. Patient might move. If they move, and you are operating on the heart, gone. So we have to give muscle relaxant repeatedly during the surgery. Muscle relaxants are also of different types. I won't go in details, you have to read about it. But if the surgery is long, we use long duration muscle relaxant. Okay? Can you name a relaxant that we use for long surgeries? Duration of action is long. Vecuronium. Vecuronium. Okay?
Gantacuronium.
Action is for 35 to 45 minutes. You don't have to give another bolus in 45 minutes. That is possible. You don't need an extra person to do that. Right? So you just have to remember, note down the timing when they give the first dose. Second dose has to be given after 45 minutes. What? Now surgery is going on, maintenance of anesthesia is going on. After 1.5 hours, it was a case of laparoscopic appendectomy. Surgeons took out the appendix, now they are doing closure. While they are closing the abdomen, they come up to skin. Now is the time that we have to prepare for reversal of anesthesia. So we discuss induction, we discuss maintenance. Now comes the role of reversal. Okay. During reversal, we want our patient to be awake, conscious, to be able to breathe on its own. We want to make sure that whatever drugs we gave are out of the system. So we know that inhalation agent they goes out quickly. The only rule, some part gets metabolized, some part comes out of the body. Okay. So how do you start your reversal? The moment you decide that okay, yeah, skin closure is going on, depending upon the agent, you can switch it off. Like for isoflurane, it takes some time to come out of the body. So you can switch it off early. Sevoflurane, while your last suture is going on, you can switch it off. With desflurane, the beauty is it's so fast acting, onset is so fast and reversal is so fast. The moment you stop it, after 1 minute, patient will open the eyes. After few minutes, patient will immediately open the eyes. So depending upon the agent, you decide when to stop. Plus, you get a monitor where concentration of the anesthetic agent is also mentioned. So here you get the concentration, MAC value, everything on the monitor. So as soon as you stop it, the concentration of the agent in the inspiratory column becomes zero because you're not giving anything. Only the expiratory concentration will be high because the agent gets absorbed by different tissues of the body. And since you're not giving inside anything, it still has to come out, right? The agent which is already accumulated in the body has to come out. So you'll see that expiratory concentration is still present and it's falling. It's falling why? Because you're not giving anything else to replenish it. Once it falls at critical level, you know that agent has come out. You have to time it with muscle relaxant also. Suppose right now it is 4:45 and your surgeon is stupid. He did not tell you that surgery is getting over in 5 minutes. And you're using vecuronium. Suppose you give vecuronium at 4:30. Surgery is over. Surgeon will sit in front of you on your head sometimes. Okay, reverse the patient. How can you reverse? You just give such a high dose of muscle relaxant. In that case, you don't have to do it. Sorry, sir. Coming to reversal, there's something called as a reversal agent that we use when the concentration of agent is already depleted. We always use reversal agent in GA and we complement it with TOF monitoring. Have you heard of TOF? Train of 4 response. So this is for the depth of anesthesia and the level of muscle relaxant in the body. If the TOF response is good, that is the time when we start a reversal agent. Reversal agents are given when you're using longer acting muscle relaxant to reverse the action of muscle relaxant. It does not reverse the action of this. Okay. What is the component of reversal agent? Neostigmine
Pyridostigmine, phygostigmine,
with
Sugamma.
glycopyrrolate.
Sugamadex.
Combination of two. Neostigmine causes rise in acetylcholine, concentration of acetylcholine, as a result of which bradycardia and increased secretions can happen. So to prevent that, we add glycopyrrolate. So it's a combination. You use that, and this is how you reverse the patient. And the first response that you get to see, sometimes patient open their eyes, you will see spontaneous breathing, and depending upon that, you can switch off the ventilator, let them breathe spontaneously. Once the patient is completely awake, you take out the tube. We don't extubate the patient unless patient is awake, breathing spontaneously, reflexes are present. So once that is done, you're absolutely satisfied that you don't have to intubate the patient again, take out the tube, and the surgery is done. This is how it goes. So induction, maintenance, and reversal. GA is kind of an art, and it requires a lot of things. One regional, for example, spinal anesthesia, it's type of regional anesthesia. You give the drug. What drug we use in spinal? Which drug do you use in local?
Bupivacaine.
So these are local anesthetic agents. The one that we gave IV was IV anesthetic agents. Okay, so your bupivacaine or lignocaine, which you use for local, can be used for spinal also. In spinal, we prefer bupivacaine. We don't use lignocaine because duration of action is very short. When you're doing small surgeries, then you can try lignocaine, which is not readily available also. Action is very unpredictable. So for spinal, the safest drug is bupivacaine. Concentration is 0.5%. And we call it bupivacaine heavy. Okay. Why heavy? Because